Hi, this is Brian Kim. I'd like to share with you this case that was referred to me. This patient underwent a YAG capsulotomy and was found to have a dislocated IOL upon follow-up. When I saw the patient, the lens was severely subluxed, but I was hoping I'd be able to get it in time without having to get retina involved. So as you can see here, I start to make my incisions. I'm a little bit concerned because I don't see the lens during these maneuvers. Tangential incision is from my AC maintainer. I'm pasting viscoelastic in the anterior chamber. I make my triplanar corneal incision. As I make the incision on the right side, I can see that there's a lens there. I'm making my mark for the trocar and then placing the trocar and tunneling about 2 millimeters away from the spot, and then I'm diving down, and this creates a self-sealing incision. I decide to go ahead and get a 23 gauge micrograsper to grasp the lens, and lo and behold, I thought that this was going to be a dislocated lens of a lens bag complex nature. However, this was just a single piece lens just floating, dangling by itself. And so I was fairly lucky. I was able to prolapse the lens into the anterior chamber, and then I cut it almost all the way through, and then I handshake the lens out through the main incision. I was hoping to be able to get the whole lens out in one piece. However, I had a little bit of trouble doing this, and so I had to amputate this lens in half and then take the other piece out separately. I'd like to share my thoughts on this situation. We're traditionally taught that you need to do a vitrectomy before you start to do any of these maneuvers, but I found that if you do a vitrectomy, you're going to collapse the vitreous space, you're going to cause the sclera to collapse as well, and it makes intraocular manipulation a lot more difficult. And so in these situations, in some cases, I feel like you can fill the anterior chamber with a lot of viscoelastic, fill even the anterior vitreous space with a lot of viscoelastic, and this firms up the eye and it creates a little bit of a support system to buoy the lens as you try to get that lens out. And so in these cases, I like to not do the vitrectomy first. I'm able to get the lens out confidently without it falling into the vitreous space. And so, again, I know that can be controversial and depends on the circumstance. But when I'm pretty confident I don't see any vitreous in the anterior chamber, I feel pretty confident in doing it this way. So here now I put the AC maintainer in and I'm performing my anterior vitrectomy. As you can see here from all that manipulation that I did, there is no vitreous to the wound. There's nothing that appears to be anything near vitreous in the anterior chamber or to the wounds. I take this Maltzman, and lo and behold, I see that this patient has excellent sulcus support. And so I'm thinking, okay, I don't really have to do a Yamane in this case. This patient still has an anterior capsular rim, and this lens must have dislocated, I suppose, because the posterior capsular rent was just too big, and when the YAG capsulotomy was performed, it caused the lens to deep 6. And so you see here I'm injecting the 3-piece lens and using the Maltzman to go ahead and place that trailing haptic into the sulcus. I'm performing a little bit more vitrectomy just to ensure that there's nothing in this space. Again, nowhere during this entire case did I encounter any vitreous at all during the maneuvers. And after I perform a little bit of vitrectomy here, I go ahead and perform my vitrector-assisted peripheral iridectomy. I have a separate setting for this, and it's got a high vacuum setting with a low cut rate, and this creates very small, perfectly sized peripheral iridotomies. And I do suggest doing it this way. It makes it a lot easier. It's less traumatic. I'm placing a tenonylon suture through the main incision. Again, this is more precautionary, a belt and suspenders approach, because I don't want to invite any vitreous into the anterior chamber, especially if the patient rubs the eye or touches the eye, which certainly can happen. Go ahead and hydrate my incisions, and after doing so, I use the forceps to pull the trocar out and immediately massage with a Q-tip. You want the AC maintainer to be active, so it provides pressure inside the vitreous space to help seal the incision. You can see there's no leakage coming from the sclerotomy. I pull the anterior chamber maintainer out and hydrate my incisions. I'm injecting a little bit of subconjunctival lidocaine first to provide some comfort to the patient, and then I go ahead and inject the subconjunctival ANSEF. And this is the end of the case. So not every dislocated IOL is the same. In this case, this was not a lens bag that was dislocating. This looked like perhaps this patient had an intraoperative complication with a posterior capsule rupture, and they had a single piece lens in the bag. And when this other surgeon came to YAG it, the lens dislocated. This patient was 20/30 uncorrected on post-op day 1 and was delighted that the vision returned. I hope this was helpful to you, and thank you for your attention.